Bonjour et bienvenue à Ottawa. Thank you very much, Bob, for that very warm introduction. So I have to start by asking, who in the audience suffers from TAS? T-A-S, theory-averse syndrome. I can spot it a mile away. Eyes start to roll. People start to huff. When it gets really bad, people start to hyperventilate, and then they faint. So if you're feeling that way, there's 2 emergency exits. We have physicians in the room, and hopefully this won't be too painless. But since you're in the business that you're in, do you think you could come up with a vaccine for me? So what I'm going to try to do, if I can, oh, there we go. So why are you here, and why am I here? Well, it has to do with all of the research. In CIHR, our budget's $1 billion a year. So we fund a lot of research. Some of it fundamental basic research, some of it clinical, some health services, population and public health. So why do we care about knowledge translation? Well, the people that would benefit from the research that's being produced are really busy. And our typical way of communicating is by publishing, and they don't actually have time to read. And if you take physicians, it's something like, for a physician now to keep up to date, they'd have to read for 17 years straight. The other thing we know is when you look at the findings in journals, the quality is actually quite variable depending on the study, and there's all sorts of reasons for that. What do you do with hundreds of thousands of papers in a particular area? Not terribly useful for a practicing clinician who wants an answer to a question to have to go through hundreds, sometimes thousands of papers. So synthesis becomes really important in terms of actually aggregating the international literature. The distinction between what, and knowing how, right, become really important, especially if it's the how that we want to influence people. And another challenge that we sometimes have relate to curiosity-driven research. That's how science actually evolves. We need to do that. People have to have great ideas. They have to be able to do their research, and in time, wonderful things can happen. Sometimes they're dead ends. That's just the way it is. On a knowledge, and so we need that. And so I'm not arguing against curiosity-driven research at all. But on the other end of the continuum, we actually have people who have questions and problems. The Public Health Agency have needs for research and for the findings. And so how can we find ways to actually drive research that's addressing those kinds of issues? So these statistics come from the US and Holland. 30 to 45% of patients don't get treatments that are known to be effective. So we're not talking about the situation where we're not sure what to do. We know what to do. It's not happening. The public is more concerned with the second bullet. Up to a quarter of people actually get things that they don't need, or worse, are actually harmful. So we've got this disconnect between what we know we should be doing or not doing and what actually people are getting. So as you think through the knowledge translation issues, it then becomes, if we have all this research and you're producing this, a lot of this important research, but if it's not actually going to be used in decision making, it's not going to affect anybody, which is the whole reason why you're doing the research to begin with. So knowledge translation, what exactly am I talking about? So this is the CIHR definition, and the reason why we use, and there's a whole, and this is one of the problems, there's lots of terms that are used. So implementation, knowledge utilization, research use, dissemination and implementation, tech transfer, commercialization sometimes fall in this category. CIHR uses the term translation because it's actually in the act that created CIHR in 2000. So we have 2 parts of the mandate, which is the creation of new knowledge according to internationally accepted standards of excellence, and its translation into, you see the bottom part, improved health for Canadians, more effective health services and products, and a strengthened healthcare system. So CIHR's definition of KT is, well, it's a process. It's not an outcome. The outcome is improved health. How do you get the improved health? Well, through synthesis, dissemination, exchange, and ethically sound application. And in the next slide, I'll go through that for you. And if you Google knowledge translation, this is often the definition that will come up first. The bottom part in italics is also part of the definition. It's the context, which often doesn't get picked up when people are citing it. So the process takes place in a complex system of interactions between researchers and knowledge users that may vary in intensity, complexity, and level of engagement depending on the nature of the research and the findings, as well as the needs of the particular knowledge user. So it's not going to be a one-size-fits-all. It depends. Are the findings really strong and there's no doubt about them? They're not being contested. We know the vaccine works. People need to be using it. Is it we think that this is promising, but we're not ready to say that everybody should get the vaccine yet? And it depends on the context. Are we in the middle of a pandemic where you might decide to go with something that there's less evidence for, but better to do that than not to act? So synthesis. Methodological approach for actually making sense of the literature in an area. So that's how we actually know we've got enough knowledge and it's strong enough to actually do something with it. Because the concern is premature dissemination of findings that actually aren't ready to get out there, that can have as much damage, especially for the public. Dissemination. So the traditional way of thinking about it is really not dissemination, it's diffusion. You get a grant, you write up your findings, you publish it in the best journal that you can, and the assumption is that there are people out there, your colleagues, decision makers, clinicians, who are very motivated and are going to look for your paper. And they're going to have the skills to be able to find your paper, and they are also going to have the skills to be able to critically appraise it, and because they've gone through all of that, they will actually then apply the findings. Well, it doesn't work. We know that. It's not too bad if the audience are other researchers, because they actually read the literature for that purpose, but nobody else does. Dissemination is, okay, you figured out what the message is, and I'd encourage you to look at your own journals. How often in the conclusions, it doesn't actually say what the message is, right? And what decision makers want are actionable messages, right? So we say the results show and our 95% confidence interval is. But are you saying they should adopt this or not adopt it or wait or whatever? So what's the message? Who's the audience? How are you going to get it to them? So it's a little bit more active than the diffusion piece because it's all based on the other person figuring out that it's there. The diffusion is, well, I'll actually get it to you. So I know that I've reached potentially all of you in the room if you don't pass out by the end of the day, right? Knowledge exchange. So this is the concept of co-creation of knowledge, and I think a lot of your research, from what I've been hearing, actually fall into this category. So sometimes it's referred to as participatory research, participatory action research. In the UK, they refer to it as mode 2 knowledge production, but it's the notion of somebody's got a problem, and they work with researchers to actually solve that problem. And so it really is a two-way street, as opposed to, I have an idea, I do my study, and now I've got to find out, well, who would use my findings? And now I've got to convince you that you have a problem that my findings address. And then ethically sound application. So I just want to remind you that all research, by definition, that CIHR funds is ethically done. If you involve humans, you have to go through a research ethics board. So unless there's fraud involved, all research we fund is ethical. So why would we be concerned about the ethical application of research that has been done in an ethical fashion? So I'm going to pause and let you think about this and tell you another story. So I'm expecting somebody to shout something out, so just be prepared. In the knowledge translation literature, one of the things we do is look at the effectiveness of different strategies to influence other people's behavior. And what we know is what I'm doing now is totally ineffective. There's nothing that I'm going to tell you that's going to affect your behavior in any way. That's what the literature says. If we did this in a small group session and problem-based learning, that's much more likely to influence people's behavior. What I can say is we know that this approach, this didactic approach, I can influence your knowledge and potentially your attitudes. So this is the piece to make it interactive that maybe you might remember. So why are we concerned about the ethical application? And the other thing to keep in mind, I'm a sociologist. I trained to do qualitative research, and one of the strategies we use with difficult respondents is to just wait and wait and wait. So, who's going to be brave? Come on. That doesn't count. So why would we be concerned about the ethical application of knowledge that's been generated in an ethically sound way?
Maybe it's
Right. There's opportunity costs, right? Researchers very seldom think about this. So if all of you had a study and had findings that had application, and I'm the public health agency, you're all coming to me saying you should do something, and I've got evidence to show it. Okay, I have to make a decision. I can't implement. I don't have the resources to implement all of your studies. So I'm going to make a decision. Do I pick your study? Do I pick your study? The evidence for both are really good. I can only implement one. That means whoever it is, the patients or providers or whoever the people who would be the focus of your research are going to be denied and potentially effective treatments. Happens all the time. Administrators make decisions of, do you implement the stroke pathway or do you implement the asthma pathway? We can't do them both at the same time or in the same year. So that's one way. The other way that it becomes important is the strategies we use to encourage people to change their or influence their behavior. I could be quite coercive and say, I'm going to take your grant away if you don't follow what I want you to do, right? It might not be legal, it may not be moral, it may not be ethical, right? We see this all the time. Torture. We don't use it in healthcare, but other sectors of society use this as perceived to be an effective mechanism for changing certain people's behavior. Well, the evidence is clear it's not. And it's illegal in most cases, right? But that's a strategy to bring about change in behavior. Application essentially is codes for use, knowledge use, and it can be instrumental use. So if you have a recommendation, people should be vaccinated under these conditions, that would be instrumental use if those people were actually vaccinated. Conceptual use doesn't lead to a behavior change, but it does lead to enlightenment. So people understand better, they have learned something, maybe their attitudes are influenced, maybe their intention to do something is actually increased, but it doesn't actually lead to the point of them following through on the recommendation. So, two more distinctions. And this goes back to what Bob was saying. When I came to CIHR after the international review, we had to kind of make things clear. So there's knowledge translation as a process, as a practice, which is about the know-do gap. So know in terms of what do we know from research, the evidence, what should we be doing, and the do, what do we do? And often there's this gap. We have evidence of what we should do, but that's not what we do. So how do we bring that and close that gap? So the WHO often refers to it as the no-do gap. But the other way to think about it is, okay, if we have findings that are relevant, strong, need to be acted on, how do we get them to the people who need to make those decisions? And how do we facilitate their ability to actually make use of those findings? Sometimes referred to as transforming evidence into practice. So the practice of knowledge translation is different from the science of knowledge translation. And sometimes these get confused in people's minds. So the science of knowledge translation, or implementation science, or implementation research, or KT research, is about, well, what are the determinants that influence people's behavior? Because if we can understand what influences behavior, then we should be able to influence those determinants. And the other way, in terms of the science, is actually doing studies to evaluate the effectiveness, for example, of didactic education sessions. Audit and feedback is another one that we know is fairly effective. So doing the studies to find out, well, what are the different ways, strategies to influence behavior, and obviously it depends on the types of research you're trying to get across, the types of people that you're interacting with, the context in which it's happening.